Welcome to Washington Hospital Today, dedicated through programs featuring community forums and free health and wellness classes. Our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing health care to the residents of the Washington Township Healthcare District for the past 60 years.
Welcome to tonight's Community Education Seminar, When Your Heart Needs a Little Help. I am Dr. Timothy Choi, and I've been a practicing interventional cardiologist in Fremont for the last 30 years. I've been the past chair of the cardiology section, as well as the past chief of staff. I've seen the Washington cardiology program grow tremendously during that time. Washington Hospital has become a receiving hospital for acute myocardial infarctions or heart attacks, and we are constantly advancing the type of cardiology services offered here in the Fremont and Tri-City area. By offering a wide array of quality cardiology services, we can optimize care in terms of time to treatment. By keeping these services locally, patient and family members no longer have to travel out of town to get treatment. Through our affiliation with UCSF and the opening of the Morris Hyman Critical Care Pavilion, we are prepared more than ever to expand. Our most recent undertaking is the development of the TAVR program. TAVR stands for Transcatheter Aortic Valve Replacement. Here to discuss this further is Dr. Ramin Beygui, who has been performing this procedure at UCSF. Dr. Beygui did his medical training at UC Irvine and completed his vascular surgery fellowship at Stanford. He is the medical director of cardiothoracic surgery here at Washington Hospital, as well as a professor of cardiothoracic surgery at UCSF. I have known and worked with Dr. Beygui now for almost 5 years. I have had confidence in referring patients to him, and he is a true gentleman to work with. And at this point, I would like to turn the meeting over to Dr. Beygui.
Good evening, ladies and gentlemen. Thank you very much, Dr. Choi, for your kind introduction. I'm Ramin Beygui. I'm a cardiothoracic surgeon, as Dr. Timothy Choi kindly introduced me. I was asked to describe one of our newer programs at Washington Hospital to you tonight. And I was wondering if I could just take a few minutes of your time and explain why this is an important subject and why it might be affecting your health. At Washington Hospital, a wide array of cardiovascular conditions are treated. This new transcatheter aortic valve, the acronym TAVR, is just a newest addition to our program. I will describe it to you with some of the heart models that I have here, what the condition is all about. If you can imagine, this is a model of the heart. The heart sits in the chest cavity like that. This structure here, the red structure here is called the aorta. That's the major blood vessel that brings the blood from the left ventricle of the heart through a valve that is in the bottom of the heart. And if you could see it through the camera, in closed position, it looks like a Mercedes-Benz sign. It has 3 leaflets. So blood, when the heart contracts, comes through the aortic valve, gets into the aorta, and then first it gives blood supply to the heart itself. So if there's a blockages in the coronary arteries, you can have a heart attack because that's the first blood supply off the aorta. And then blood continues on and bringing blood supply to your arms, to your brain, and then it goes back behind the chest and it gives blood supply to the rest of your body, to the aorta, through the aorta to the kidneys, to the bowel, to the lower extremities, to your legs, and so on. So if you can imagine, if there is some blockage at the aortic valve, at the first point of entry to the aorta, then everything that is downstream from the aortic valve could be affected. So what happens? So most of us are born with a valve that has 3 leaflets. Some of us, perhaps about 1 to 2% of us, are born with a valve that naturally has only 2 leaflets. So those patients in general are prone to having a tightness of the aortic valve that is a little bit premature. Happens at a younger age. However, the rest of us who are also born with the valves that are with trileaflets, over the years, the valve gradually becomes calcified and you will have a difficult time opening and closing. So valve acts like a door. It has to open up when somebody wants to get out, and it has to close so the wind and the cold doesn't get in. Sometimes the valve has a problem opening up. That's called aortic stenosis. sometimes the valve has a problem closing. So that's called the aortic regurgitation. So both of those conditions are usually amenable to treatment. For the longest time, for several decades, we've been treating patients with aortic stenosis very safely. Why? Because majority of the people who have aortic stenosis, they are over the age of 60 to 65. If you happen to be over the age of 65, you have about 3 to 4% chance of having an aortic stenosis. A lot of times aortic stenosis is mild and doesn't need any surgical treatment. But as the aortic valve becomes severely stenotic, a few things happen. First of all, like any other muscle in the body, when you exercise it, the muscle of the heart will get thicker. So if he has to push against a very tight aortic valve, the ventricle of the heart gradually becomes thicker. It's like you're exercising it. In general, if you exercise your arms and your legs and your muscles get bigger, is probably fine. It's a good thing to do. But for the heart, it's not necessarily a good thing because the chamber where the blood is gets smaller. And as a result, the heart becomes called the hypertrophy of the heart, becomes very thick. You know, as you can see, the heart normally looks like an American football. Then it can become rounder and look more like a basketball. So that's one problem with the heart. Sometimes the symptoms are very mild and people have no symptoms at all. Sometimes gradually the patient may develop symptoms of fatigue, shortness of breath, not being able to go upstairs easily. One of the first signs maybe when you go to your doctor and they can listen to your heart and they can hear a murmur. There's a very typical abnormal sound of the heart associated with the aortic stenosis. And if that happens, your doctor usually orders an echocardiogram, which is a non-invasive test with ultrasound to look at your heart and the aortic valve. And with that, they can grade the degree of aortic stenosis, how tight the aortic valve is, look at your symptoms, see what kind of symptoms you have, and look at the function of the heart to see how well it's contracting. Because if it has had long-standing aortic stenosis, the heart can become fatigued and a little bit lazy and not able to pump very well. So if you have symptoms, in general, those patients are referred for aortic valve surgery. Even if you don't have symptoms, but the heart shows early signs of fatigue, like it's getting too thick, or the contractility of the heart, the function of the heart is diminished, then in general, those patients are also referred for surgery. As I mentioned, for decades, we've been treating patients with aortic stenosis, even people who are in their 80s and 90s, octogenarians, nonagenarians, people who are in their 60s and 70s. The operation traditionally involves, because the heart's behind the chest cavity, involves opening the chest, putting the patient on a heart-lung machine, stopping the heart, and opening the aorta from up in here and replacing it with the valve. The kind of valves we use are usually two general kinds. For younger people in general, we use what is called the mechanical valve. You can see that it looks kind of like bat wings. It opens and closes. The advantage of these valves are that they are very durable. They last a long, long time, although perhaps not forever, but they do last a long, long time. But the disadvantage is that the patient would have to take blood thinners, probably for the rest of their lives. There is really no alternative other than a blood thinner, a medication called warfarin or Coumadin. So that's one advantage and disadvantage of the mechanical valve. There is also another choice. We can use a valve that are made either from the pericardium, which is the sac around the heart of the cow, or the leaflet of the pig, and they're called tissue valves. For all practical purposes, they look like a human aorta, except they are mounted on some sort of a scaffold that the surgeon can sew it into the heart. The advantage of this valve is that in general, the patients who have these kind of a tissue valve, this is a plastic model of it that again in closed section looks like a Mercedes-Benz sign that it opens and closes. The advantage of these valves is that you don't need to be on a long-term blood thinners, but the disadvantage is that the patient may need another valve operation 10, 15 years later. So if you can imagine that one patient has undergone open heart operation, open chest operation, and the aortic valve has been replaced, now maybe 10, 15 years later they need yet another operation, which again, that can be done safely and we can do it at Washington Hospital if it's needed. So the idea developed in about 2009, 2010, because there are some patients who are either very old or frail, or for various reasons we thought they may not tolerate a big operation like putting them on a heart-lung machine and replacing their aortic valves. And the idea was, is there a way to treat these patients without an invasive operation, without opening the chest and putting them on a heart-lung machine? So the concept was, well, is there a way that we can get a valve inside the aorta without opening up the aorta, opening up the chest? So as I mentioned before, the aorta connects with the rest of the body vasculature. So the idea was, what if you go to the artery, one of the smaller arteries that are like in the groin area, and from there you can deliver a valve. So essentially the valve is packaged into some sort of a small component, and then is delivered to where the aortic valve is. And then you expand it there where the aortic valve is, and it assumes its shape. So that concept is doable. Our cardiology colleagues like Dr. Choi and colleagues have done that, something like that, to the coronary arteries for many, many years. They put a stent into the coronary arteries and open them up, but those blood vessels are very small. Is there any way we can do it in a larger blood vessel like the aorta? And the answer was essentially yes. So there were a few trials, initially in 2011 and 2012, to see if the patients who are at a very high risk of surgery, whether this particular new technology, transcatheter aortic valve, can be usable. Initially, we operated on the patients that we initially thought that they were exactly inoperable, mainly because the risk of surgery was too high, either because they had lung disease, kidney disease, they were too frail, or various other reasons. And then the initial studies showed that they actually do well with the transcatheter aortic valve. Then other groups of patients started being tested later on. Patients who had an intermediate risk of heart surgery, and then now more recently, as of 2019, of the people who had a lower risk of aortic surgery. So what is again the concept? So you come from a remote site that is easily accessible with a small stick in the groin. You deliver valve into the aorta, you deploy it in that location, and the patient has an immediate relief of the stenosis of the aortic valve. The most recent study actually showed that patients who have an aortic valve surgery done, the transcatheter aortic valve, their outcome is even superior to the surgical procedures. Meaning why? Meaning what? That means that the risk of dying from the surgery or having a stroke or bleeding and complications like that may happen after an open heart operation are less. So this procedure has been approved by the FDA now as a standard, even for lower risk patients. As of this year, we started doing those procedures at Washington Hospital. As Dr. Choi explained, that for the past 5 years, I've been doing those operations at UCSF in conjunction with our cardiology colleagues over there. But then recently, the same group of people who also operate at UCSF can do the same procedures here at Washington Hospital. So let me go back again. If you have the other conditions of the aortic valve that I mentioned before, like the aortic valve is leaking, or if you have an aneurysm of the aorta, which is like a dilatation or enlargement of this part of the aorta, still the transcatheter aortic valve, TAVR, may not be an ideal operation for those patients. However, for the great majority of the patients who have aortic stenosis, tightness of the aortic valve, and there is a calcification of the aortic valve, those patients would do very well with the transcatheter aortic valve. So one question is, what should you watch for? Well, as I mentioned, as we all get older, over the age of 65, the risk of developing aortic stenosis increases. Perhaps 3 to 4%, sometimes 5% of us may have aortic stenosis or aortic regurgitation, tightness of the aortic valve or the leaky aortic valve. And if you have those conditions and your doctor hears a murmur, then an echocardiogram is done. And then you will be evaluated. And then you should be, if your cardiologist feels like that either the severity of the aortic valve is high enough that without symptoms, you should have something done about it, or even if the severity is not very high, but your heart, you don't have any symptoms, but the severity is high enough that your heart shows signs of problems with that, you should have taken care of before. What are the typical symptoms of aortic stenosis? There are 3 classic symptoms that people have had. One is called chest pain, angina, chest pain, because what happens when the muscle of the heart becomes very thick and then your heart starts to squeeze the blood past that very tight aortic valve, then it kind of outgrows the blood supply to it, and then people may develop pain. Kind of similar to having a heart attack, but those patients may have a completely normal coronary arteries, but they would have pain, sometimes on exercise. The other one is called syncope or fainting, especially summertime, especially if they are dehydrated. The reason for that is, as I mentioned, the heart gets very thick, so the chamber of the heart becomes very small. If the amount of volume in the chamber of the heart is not that much, but when you're dehydrated or if it's hot or you are stressed, then patients may have a fainting episode. The worst symptoms to have is called congestive heart failure. That means that the heart actually failed to work as a pump. As a result, you can develop swelling of your ankles, or your lungs can fill up with fluid. All of our efforts are to avoid those very serious complications and symptoms of aortic stenosis, especially heart failure, because it still can be treated for aortic stenosis. But if you're identified with aortic stenosis sooner, then the quality of life goes back to normal, and your survival goes back essentially to what the background population of the patient is without aortic stenosis. So those are the three classic symptoms: chest pain, having a syncope, dizziness, lightheadedness, and fainting. That's what syncope is. And the third one, having congestive heart failure. However, because the degree of aortic stenosis is rather gradual over time, patients may not have any serious symptoms right away. They just gradually avoid staircases. They may say, well, I'm older, I'm not as active as used to be. They can attribute it to aging and so on and so forth. But if you're identified to have aortic stenosis, almost all the time, that's the reason. And treating it would be very helpful. Logically, if you can imagine, you have a blockage to the outflow tract of the heart, which is the aortic valve. And by mechanically correcting that, you have an immediate relief. In my own personal experience of having treated patients at UCSF and now at Washington Hospital, the degree of aortic stenosis is directly proportional to the symptoms. And the transcatheter aortic valve is a very effective, safe way of dealing with it. And because we don't have to put even sicker patients, older patients, frail patients on heart-lung machine, the recovery is very quick. They usually stay in the hospital 2 days, 1 day, 2 days, 1 day, 2 days, or maximum 3 days, and they can go home. Even if you are younger and the risk of a heart-lung machine is not very high, the recovery and going back to work is a lot faster. So for what patients do we still offer open heart surgery? As I mentioned, would be patients who have either the infection of the aortic valve, serious leakiness of the aortic valve, aneurysm of the aorta, or if you have a concomitant problems with the aortic valve. Perhaps you have some major blockages of coronary arteries that those vessels you need to be bypassed. If you also identify that you have tightness of the aortic valve, we'll take care of that also at the same time as your other operation. So cardiac surgery in general, which is dealing with the problems of the heart, whether it's aortic valve, coronary artery disease, mitral valve, what have you, are still there. But this particular technology would allow us to treat some of our patients. Another interesting thing about the aortic valve replacement, transcatheter aortic valve replacement, is that, as I mentioned, if you had a tissue valve made from the pericardium of the cow or the leaflet of the pig, then the valve may last you about 10 to 15 years. Then at some point, 10, 15 years later, those patients would be referred for open heart surgery. And the second operation is usually more complicated and perhaps somewhat more difficult to do than the first operation. However, the transcatheter aortic valve is very usable and adaptable and amenable for patients who have had a prior operation, because you can simply get across the old tissue valve and then put a new valve inside the old valve and then have the treatment done instantaneously. So again, you're treating patients who are at high risk of operation, which is the reoperative second heart operation for aortic stenosis, and you can treat those patients with a transcatheter aortic valve. And still, those patients can go home within 1 day, 2 days, 3 days of their procedure. So those are all exciting times. With that, I'm not sure if I have any other additional comments, but I'll be happy to answer any questions that the audience can have. And as a last comment, I would like to say, as sort of a take-home message, that if you feel like you're fatigued, there might be something wrong with your heart, refer to your doctor, your cardiologist. They can do non-invasive tests. And if happens to be your aortic valve and has tightness of the aortic valve, don't worry, that can be treated very easily, and you will be home within a day or two, great majority of the time. Thank you.
Okay, so we do have a question. The first question is for Dr. Choi. My primary physician referred me to a cardiologist for a full evaluation. Should I wait to see the doctor?
Well, without knowing your symptoms, you should refer to your PCP or your primary doctor and see how urgent your situation is. If it's urgent, then the PCP or your primary should contact us, and we'll be happy to get you in as soon as necessary or as soon as possible. But for some occasions, you can wait, depending on what your conditions and symptoms are. Don't let COVID stand in the way of your evaluation, however. If you have a symptom or something that needs to be evaluated, COVID shouldn't be the reason that you delay.
Great. Thank you. This question is for Dr. Beygui. How important do you think it is to adopt new treatments and procedures when your medication is not working?
That's a very good question. I think the problem, at least with respect to the cardiac disease, is that a lot of times we try to manage the patients with medication. As I mentioned, even for heart failure, aortic stenosis, there are a lot of very good medication that we can use. But the problem is if the medications are not working, and if you still continue to do either medical management or even worse, perhaps not complying with your medication, then you can get to the point that then the treatment becomes either more difficult or perhaps even at some point maybe useless. For example, in this context of aortic stenosis, if you let the condition last a long, long time, then you may get to the point that you would have developed heart failure. So you can still be treated, but perhaps with a high risk, or even if you wait a very, very long time, perhaps the treatment at that point may not be effective if the heart itself has failed to work.
Okay, great. Thank you. Dr. Choi, does a heart health impact my risk for COVID?
Definitely so. The risks for COVID are many. If you were to contract COVID and all other things being equal, age, gender, and other medical conditions, if you have heart disease on top of it, it definitely increases your risk of comorbidity and death, possibly as high as 10%.
Dr. Beygui, you mentioned fatigue as one of the symptoms. What other symptoms should I watch for that may indicate that my heart valve disease is getting worse?
Thank you very much. So yeah, fatigue and tired and inability to do what you used to do, one of the most common signs of early heart disease, valve disease. The other symptoms, as I said, as the condition progressed, would be inability to tolerate hot weather, or during the time that the weather is very warm or you're dehydrated, you may get dizzy or lightheaded. If you wait a very, very long time, then you may develop more serious symptoms, which are attributable to heart failure, like you're very short of breath even at rest, or you use multiple pillows at night because you cannot lie flat, or if you look at your ankles, the ankles become swollen. Your cardiology doctors would be are expert basically to recognizing those symptoms and initially starting with non-invasive tests to identify what the cause is. And then if there's a medical treatment for it, they will initiate that. And then if at some point the symptoms are severe enough and it happens to be a structural problem with your heart or your valve, then you may require surgery.
Great. Thank you. Dr. Choi, what heart conditions or symptoms should trigger an immediate phone call to my doctor?
Well, as cardiologists, the main thing we worry about are symptoms related to having an acute heart attack. Those symptoms, to list those would take a whole nother talk, but basically symptoms of chest discomfort with exertion, shortness of breath, passing out, along with risk factors for heart disease. If you have any of those, that could warrant a call at least to your physician, whether he's a cardiologist or a PCP, to get the ball rolling to see if you need more urgent care and going to an emergency room. Again, don't let COVID delay that phone call. If you've been having symptoms of possible angina, chest pain from coronary disease, you should get on it right away and call somebody and not wait for COVID to be over, because who knows when that'll be.
Great. Dr. Beygui, if my valve problem is not serious, what do I need to do to monitor it over time?
That's also a very good question. I think the best thing is to follow up with your primary care doctor and fortunately and hopefully with your cardiologist. And then your cardiologist on a regular basis can do non-invasive studies to assess the function of your heart and the degree of the problem with the aortic valve. Actually, another valve that I did not mention is the mitral valve. More people have problems with the mitral valve than they have with the aortic valve. But it's very common to have a mitral valve problem that it does not become severe and it does not cause any serious problem for the longest time, from a younger age to an older age. and your cardiologist would be the best person to follow you on a regular basis, depending what your symptoms are.
Okay. Dr. Choi, is it safe to have surgery during the COVID pandemic?
Yes, it is safe to have surgery during the pandemic. For any urgent and emergent surgery, there should be no delay whatsoever in having your surgery in the presence of COVID. For those of you that are planning elective surgeries, they should still be planned, but there's always a possibility if there was a surge in COVID that hospital beds may be tight, and for that reason, some elective or semi-elective surgeries may have to be postponed.
Okay, I have another question. Dr. Beygui, what will happen if I choose not to receive treatment for my valve disease?
So the progression of valve disease is a problem. The heart is a very important organ, as you can imagine. It works as a pump. So either leakiness of the aortic valve and tightness of the aortic valve, or the mitral valve for that matter, both of them can cause problems. The leakiness of the valve, either whether it's an aortic valve or a mitral valve, would be akin to have a small boat that has, is shipping water. So if the role of the person is to row to a destination and your boat continuously fills up with water, and then you have to stop every so often and get a bucket to throw the water out, then eventually that person is going to get fatigued. The same with the heart. And if the heart has to work extremely hard to keep the blood out of the heart and keep pumping it, it will get tired. The whole idea is to avoid the symptoms that are severe and life-threatening, and then also not get to a point that the condition of the heart is irreversible. And that can happen, that those patients are actually called end-stage heart disease because of the valvular heart disease or diseases of the valve. Then there may not be a lot of very good medical options, and perhaps even heart transplantation may be an option for those patients. However, if they're identified sooner, before we get to the point that the heart itself is affected badly by the valve disease, then the treatment options are a lot more straightforward and almost invariably very, very successful.
Okay, that concludes our program for this evening. Thank you, Dr. Choi. Thank you, Dr. Beygui, for your expertise. And thank you to our viewers for tuning in. The entire broadcast of this evening's event will be available on our Facebook page and YouTube. Thank you again.